All right, good morning everyone. Today is Wednesday and we're going to be doing class 6. Today we're going to be covering therapeutic modalities. So we're going to go through and look at the kinds of things that athletic trainers use in the training room to treat sports injuries or conditions that could be acute or chronic. So we're going to go through and talk about what those look like. This is a class that I really wish could have been hands-on. It's so much easier for you guys to see and use these modalities and feel what they feel like, so you'll be able to explain them to a patient. But unfortunately, we're not able to do that. So I will link some YouTube videos in these slides so that you guys could go in and watch those videos as more of a way for you to see what these modalities are doing and get an idea of how to use them, what they look like when they're in use. I know some of you have been athletes or are athletes with SPU, so you may have had these done on you. But now we're going to talk about a little bit of the science of why they work, why we use them, maybe why we don't use certain things in certain situations. So we're going to go through all of that today. There are slides again, going through those. I will talk about which slide I'm going through. So we'll get started on slide 2 and talk about why do we use therapeutic modalities. Therapeutic modalities and medications are used to create an optimal environment for injury repair by limiting the inflammatory process and breaking that pain spasm cycle. So in the last slides on Monday, we talked about the gait control theory. And that kind of comes into play here when we're looking at some of the therapeutic modalities that we use, because we can use the modalities to inhibit the gait control theory. So that's something that we can talk about a little bit later, and which modalities those would be. So when we're using a modality to treat an injury or a condition, we want to look at indications or contraindications. So why would we use this modality, or why wouldn't we use this modality? So an indication is a condition that could benefit from a specific modality, and a contraindication is a condition that could be adversely affected by a particular modality. So as we're going through, for each modality, there's a table that will tell you contraindications and indications for that modality, and those are really important. A lot of the contraindications are the same for a lot of these modalities, but reasons to why you would use them are going to be pretty different. So on slide 3, we're looking at therapeutic modalities in general. So we're initially going to address the basic principles associated with the electromagnetic spectrum and the factors affecting the transfer of energy. Then we're going to look at more common therapeutic modalities used in injury management. The material is presented in a general overview of these modalities because of the extensive information and clinical skills that are needed to adequately comprehend and apply therapeutic modalities in a clinical setting. This chapter should not be used as your only gateway to these modalities. Like I said, I wish that we could do these in the athletic training room. I wish we could have a lab and go through all of these together, but we can't. So using the video, the book, and YouTube, hopefully you guys will get a good overview of what we're looking at. If you do continue on into an athletic training program or even PT, you will learn how to use these modalities. You will get hands-on experience in a lab and using them on patients. So we'll start on slide 4. We're looking at the electromagnetic spectrum. Let's see. So on a daily basis, the environment is impacted by several different varieties of energy forms. So each form of energy falls under the category of electromagnetic radiation, and it can be located on an electromagnetic spectrum based on its wavelength or frequency. Electrical therapeutic modalities are part of the electromagnetic spectrum, which is divided into 2 major zones. We have the ionizing range and then the non-ionizing range. Again, that's something we're not going to go too specific into. We will move into electromagnetic or electrotherapy towards the end of the slides, but just knowing that it separates into 2 zones is what I'm expecting of you guys right now. On slide, again here, we are looking at just this spectrum as a whole. So we're looking at energy. On slide 5, we're going to talk about the transfer of energy. So electromagnetic energy can travel through a vacuum and with no transfer medium. So energy moves from an area of high concentration to an area of lower concentration by energy carriers such as mechanical waves, electrons, photons, and molecules. So this energy flow in the form of heat involves the exchange of kinetic energy or energy possessed by an object by virtue of its motion and is transferred via radiation, conduction, convection, conversion, or evaporation. So those are our 5 ways to transfer energy, and we're going to go through and talk about what each of those are. So the first one is radiation. Radiation is the transfer of heat in the form of infrared waves without physical contact. So all matter radiates energy in the form of heat. Usually, body heat is warmer than the environment, and radiant heat energy is dissipated through the air to surrounding solid, cooler objects. When the temperature of surrounding objects in the environment exceeds skin temperature, radiant heat is absorbed. So shortwave and microwave diathermy are examples of both radiant energy transfer, but they can also heat by conversion. And then the diathermy is not a modality that we're going to cover today. It's not super common anymore. It's kind of old school, so we're not going to go through that one. The next one is conduction. Conduction is the direct transfer of energy between 2 objects in physical contact with each other. So a difference in temperature is necessary to initiate the movement of kinetic energy from one molecule to another. And the energy moves from an area of high temperature to an area of lower temperature. So examples of conductive thermal agents are ice bags, ice packs, moist hot packs, and paraffin. Again, all of those we're going to go through in a little bit. The third transfer of energy is convection. Convection is a more rapid process than conduction, and it occurs when a medium such as air or water moves across the body, creating temperature variations. The effectiveness of heat loss or heat gain by conduction depends on the speed at which the air or water next to the body is moved away once it becomes warmed. So for example, if air movement is slow, the air molecules next to the skin are warmed and act as insulation. In contrast, if warmer air molecules are continually replaced by cooler molecules, heat loss increases as the air currents carry heat away. Fluidotherapy and whirlpools are examples of therapeutic modalities that exchange energy by convection. Fourth, we have conversion. So conversion involves the changing of another energy form into heat. In ultrasound therapy, mechanical energy produced by high-frequency sound waves is converted to heat energy at tissue interfaces. In microwave diathermy, high electromagnetic energy is converted into heat, which can heat deep tissues. Chemical agents such as balms can create heat by acting as counterirritants to superficial sensory nerve endings, thus reducing the transmission of pain from underlying nerves. So using something like icy hot would be an example of that. The last form of transferring energy is evaporation. Heat loss can occur during evaporation. Vapocoolant sprays, for example, spread a liquid over the skin surface. The heat absorbed by the liquid cools the skin surface as the liquid changes into a gaseous state. Evaporation also is the means by which the body cools itself on a hot day through the evaporation of sweat. We're going to talk a little bit about the vapocoolant sprays, but they are very, very old school. There's really no research to support them anymore, but we will talk about them a little bit in the cryotherapy section, which is where we're moving next. Slide number 6 is our start of cryotherapy. All right, so cold application or cryotherapy describes multiple types of cold application that use the kind of electromagnetic energy which is classified as infrared radiation. When cold is applied to the skin, which is a warmer object, heat is removed or lost. This is referred to as heat abstraction or cooling. The common modes of heat transfer with cold application are conduction and evaporation. Cold application for less than 15 minutes causes immediate skin cooling, cooling of subcutaneous tissue after a slight delay, and cooling in muscle tissue after a longer delay. This can lead to decreased cell metabolism, decreased inflammation, decreased circulation, decreased pain perception, decreased muscle spasm, decreased muscle force production, and increased tissue stiffness. Depth of cold penetration can reach 4 to 5 centimeters, and it's dependent on the duration of the treatment. The longer the treatment, the greater the depth of cooling, and the greater the decrease in temperature. We're talking about, so looking at that temperature change on slide 7, we're going to look at the magnitude of temperature change and what that depends on. So again, the depth of cold penetration can reach 4 to 5 centimeters, but all of these things on slide 7 are factors that affect how deep the cooling can go. So we're looking at what type of cooling you're using. Are you doing an ice massage versus an ice bath? The temperature can differ a lot between those. And then you're looking at temperature difference between the cold object and the soft tissues. You look at, are you using a compression wrap to secure the cold agent to the injured area? You look at an insulating medium between the skin and the cold agent. So is the person wearing any clothing between their skin and whatever ice modality you are applying? You look at the amount of subcutaneous insulation, so adipose tissue and fat. Is there more insulation or less insulation in that area on that individual? You're looking at the depth of target tissue, so there are some muscles that are superficial, some muscles that are larger and deeper. So how deep is the tissue that you want to be cooling? We're also looking at vascularity and thermal conductivity of the area being cooled. You look at limb circumference. How large is the person that you're cooling or putting this cryotherapy on? Sympathetic nervous system can have something to do with this as well, and the temperature changes that can happen. Does a person have hypersensitivity or decreased sensation? That can change how you're cooling as well. And then lastly, duration of the application. So you want to follow certain instructions for different types of therapy. Not going long enough will not give you appropriate response of tissue cooling, but going too long could possibly damage the tissue as well. So knowing those ranges is very important. So looking at slide 8, we're talking about why do we use cold therapy? And this modality can be somewhat controversial. There is research to support cold therapy. There's research to support not using cold therapy. There is ideas to use it in certain situations and ideas to use it in, or to not use it in certain situations. So it's very different across the board. But for the sake of this, we're going to look at cold therapy is used to lower the temperature in soft tissues, to reduce pain, and to control edema. So cold application leads to vasoconstriction at the cellular level and decreases tissue metabolism. And so it decreases the tissue's need for oxygen, and that will reduce secondary hypoxia. Capillary permeability and pain are decreased, and the release of inflammatory mediators and prostaglandin synthesis is inhibited. So as the temperature of the peripheral nerves decreases, a corresponding decrease occurs in nerve conduction velocity across the nerve synapse, increasing the threshold required for the nerves to fire. So here we're looking at the gate control theory. So the gate theory of pain hypothesizes that cold inhibits pain transmission by stimulating large diameter neurons in the spinal cord, acting as a counter-irritant which blocks pain perception. Because of the inhibition of nerves and muscle spindle activity, muscles in spasm are relaxed, breaking the pain spasm cycle and then leading to analgesic or a pain-free effect. So during ice application, a decline in fast twitch muscle fiber tension occurs, resulting in a more significant recruitment of slow twitch muscle fibers, thereby increasing muscle endurance. So also on this page, or on slide 8, I have listed the box of indications and contraindications for when you would use ice and when you would not use ice. You can go through those on your own. The table is pretty self-explanatory, but if you have questions about why you might or might not use ice, please ask, because there's a ton of stuff out there. On slide 9, we're looking at types of cryotherapy. First and foremost, the most common is a cold pack. Cold packs are administered in 4 common methods: plastic bags filled with crushed ice, reusable cold gel packs, we have controlled compression therapy units, and then we also have instant cold packs. So we'll look at each of those. So the first one is an ice bag. So when filled with ice or small cubes, ice bags can be safely applied to the skin for 30 to 40 minutes without danger of frostbite. Ice packs can be molded to the body's contours and held in place by compression wrap or like saran wrap or flexi wrap. And then the injured area can be elevated above the heart to minimize swelling and pooling of the fluids in the interstitial space or the tissue spaces. So during initial treatments, the skin should be checked frequently. They could have a cold allergy, which is not uncommon. So you want to look for rashes or any reddening that's abnormal. A disadvantage of this application method is the cost of an ice machine can be expensive, and then you always have to be buying ice bags and flexi wrap because those things you can't reuse. Which brings us to reusable cold packs. Reusable commercial gel packs, those contain silica gel enclosed in a strong vinyl or plastic case, and they come in a variety of sizes to conform to the body's natural contours. I actually have one, hold on. So this is a kind of ice pack. This one can actually be used for hot or cold, so you can move it around. I can refreeze it all the time, and it's jelly inside, so I can contour this as well. It doesn't contour as good as a ice bag, but this will do pretty well if you just need something to have on hand at home. We don't typically use these in an athletic training room. We would have to clean it every time someone used it. The integrity of these can be lost quite fast, so it's not really feasible to use these. But if we're traveling, these aren't a bad thing to have in in your bag, and then you plop it in the freezer in your hotel room or things like that. Again, this one can also be used for hot, but typically these are used only for cold. So you use those with compression and elevation, just like the ice bag. They're an effective method of cold application. They are, again, not super expensive, but you would have to replace them a little bit more often. Because they're stored at a sub-zero temperature, it may cause frostbite if you don't use them properly. A wet towel or a cloth should be placed between the pack and the skin to prevent frostbite and to maintain a hygienic surface. So like I said, so we're not having to wash them every time you use something in between these, between the pack and the skin. And then treatment time for those reusable packs range from 15 to 20 minutes. Next mode of therapy or cryotherapy that we're looking at is a controlled compression unit. So controlled compression therapy units use static and external compression and cold. They use this application to decrease blood flow to an extremity and to assist in venous return to decrease edema, and to increase the effective depth of cold penetration. So in doing so, both pain and recovery time are decreased. The most common kind that is used now is called a game ready. I can put a picture of that on the slide for you guys. I think, yes, I did. It's a shoulder sleeve, and the girl is holding, she has a sleeve on her shoulder, and it is running ice water through the sleeve and cooling the entire area. And it's also applying compression, so it's getting tighter and very cold. So that is all concentrated in one spot. They're often applied after surgery because you can apply them over dressings. You can apply them over casts, but it doesn't necessarily get cold enough to penetrate a lot of those post-surgical casts. Some units provide a motorized or intermittent compression treatment when cold water is circulated through the boot or sleeve. It can be used intermittently. So some people, when they use it post-surgery, they will sleep in it, and then the Game Ready will turn on and off throughout the night. Once an hour, it will go through cycling. The unit can be used several times a day, but never, you don't want to use it over a fracture, or if you think the person has compartment syndrome. Those are certain things that you would not want to compress, because this unit, you can't control how tight it gets. Well, you can. There's 3 levels on it: high, medium, and low. But again, you can't control anything more than that, so there's only 3 levels. Then the last one is instant cold packs. So this is using a chemical. And these are convenient to carry in your athletic training kit if you're going somewhere just for the day and you're not sure what supplies they're going to offer you. They can be disposed of after a single use, and they conform to a body part just like the other one that I showed you. Each bag contains 2 chemicals separated by a plastic barrier, and when the barrier is ruptured, the chemicals mix, which produce cold. These are not super common. A lot of places will have an ice machine now, so ice bags are the most common, and then these instant cold packs are used more for things like intramural sports or in basic first aid kits. Next one is an ice massage. So ice massage is very inexpensive, and it is an effective method of cold application. It's performed over a relatively small area, such as a muscle belly, a tendon, a bursa, or a trigger point. It produces significant cooling of the skin, and it increases blood flow to the region once the treatment has ended. So it is not the treatment of choice in cases of an acute injury. You don't want to use it right away after someone is injured. Ice massage is particularly useful for analgesic effect and use in chronic injuries. So its analgesic effect is used in relieving pain that may inhibit stretching of a muscle, and it has been shown to decrease muscle soreness when combined with stretching. So it's commonly used for or before range of motion exercises and before deep friction massage when treating chronic tendinitis and muscle strains. Treatment of this, you can see on the slide, it's the frozen cup. So it consists of water frozen in a cup or a reusable plastic container, which is rubbed over an area using small overlapping circular motions for 5 to 10 minutes. A continuous motion is used to prevent tissue damage. If this treatment is applied properly, skin temperature usually will not drop below 15 degrees Celsius or 59 degrees Fahrenheit. Therefore, the risk of damaging tissue and producing frostbite is very minimal. During ice massage, the stages of cold, burning, and aching will pass rapidly within approximately 1 to 2 minutes. A prolonged aching or burning sensation may result if the area is too large or if the individual has a hypersensitive response. Our next one is ice immersion or an ice bath. The tub that is in the picture on there is what is most commonly used for this. It is a large tub, and then athletes can sit inside. They can dip their feet in, they can go in up to their knees, their hips, or some people even sit in it and go all the way, depending on what they're using the ice bath for. So ice immersion is used to reduce temperature quickly over the entire surface of a distal extremity. A variety of containers or basins can be used. Because of the analgesic effect and the buoyancy of water, ice immersion and cold whirlpools often are used during the inflammatory phase to reduce edema formation after blunt injury. If the goal is to reduce edema, placing the body part in a stationary position below the level of the heart keeps the fluid in the body segment, and it's contraindicated. This can be avoided by placing a compression wrap over the body part before submersion and performing active muscle contractions. Neoprene toe caps can be used to reduce discomfort in the toes. That is very common. The toes are going to be the ones that get cold the quickest, and so protecting those is a little bit more important. So cold whirlpool baths also provide a hydromassaging effect. The intensity of the effect is controlled by the amount of air that is emitted through the electrical turbine. The turbine can be moved up and down or directed at a specific angle, and it can be locked in place in some of these tubs. The whirlpool turbine should not be operated unless water totally covers the entire impeller. And in addition to controlling acute inflammation, cold whirlpools can be used to decrease soft tissue trauma and increase active range of motion after prolonged immobilization. One reason you would not go in a cold whirlpool is if you have any open wounds. Everything that is open has to be covered before you go in a whirlpool, or don't go in the whirlpool at all. It is a place where that it's a common therapy, and so different athletes use it throughout the day. If you go in with an open wound, then all of that gets into the water, and then it can be contracted through other people. So if you have an open wound, definitely don't go in the ice machine or the ice bath. So lastly, we're talking about these vapocoolant sprays. It's a non-flammable, non-toxic spray that uses rapid evaporation of chemicals on the skin to cool the area before treatment of trigger points. Or like in soccer, a lot of times it's called magic spray. The athletic trainer will run out, they have an injury, they spray on the cold spray, and magically they're all better. The effects are temporary and very superficial, so when using a vapocoolant spray to increase range of motion, where no trigger point is present, the patient should expect to feel something very cold and then have an instant relief. This relief does not last long at all. Neither does the cold feeling. You want to spray approximately 12 inches away from the skin, and you spray the entire length of the muscle 2 or 3 times in a unidirectional parallel sweeping of the pattern as a gradual stretch is applied by the clinician up to, but not exceeding, the point of pain. You want to allow the tissue to re-warm, and then repeat the process with 2 or 3 more sweeps with increasing stretch placed on the muscle. The treatment could also be followed by a moist heat treatment or massage. Again, not super common, not really research backed anymore, and so those are not used hardly at all. Moving on, we're moving on slide 10 and looking at thermotherapy. Alright, so thermotherapy, or now we're looking at heat application, typically is used during the second phase of rehabilitation to increase blood flow and promote healing in the injured area. If used during the acute inflammatory phase, heat application can overwhelm the injured blood and lymphatic vessels, leading to increased hemorrhage or edema. When applied at the appropriate time, however, heat can increase circulation and cellular metabolism. It can produce an analgesic effect or a sedative effect and assist in the resolution of pain and muscle guarding or spasms. Vasodilation and increased circulation result in an influx of oxygen and nutrients into the area to promote healing of damaged tissues. Debris and waste products are removed from the injury site. Because the blood flow is increasing, it's helping to flush out all of that stuff that could be building up inside. Thermotherapy is used before stretching exercises. It can be used before joint mobilization, and it could be used for active exercise. It can also increase the extensibility of connective tissue, leading to increased range of motion. In the same manner as cold application, heat flow through tissue also varies with the type of tissue and is called thermal conductivity. So looking at slide 11, why do we use thermotherapy? Superficial heating agents involve the transfer of heat through conduction, convection, and radiation. Common examples of superficial thermotherapy are warm whirlpools or immersion, moist heat packs, paraffin baths, fluidotherapy, and infrared lamps. Penetrating thermotherapy, including ultrasound, phonophoresis, and diathermy, are discussed a little bit later when we go into ultrasound. So when we are doing, to attain therapeutic effects from vigorous heating, the tissue temperature must be elevated to between 104 to 113 degrees Fahrenheit. Within these temperatures, hyperemia, which indicates increased blood flow, will occur. Potential tissue damage can occur with temperatures above that range, and tissues below this range are considered to be only mildly heating, and they are insufficient to stimulate cellular metabolism enough to cause therapeutic effects. Changes in surface tissue temperature caused by superficial heating agents depend on the intensity of heat applied, the time of heat exposure, and the volume of tissue exposed. So again, going back to what we talked about with the cryotherapy and the magnitude of how the temperature changes, those same things apply here for heat therapy. Excuse me. So also on slide 11, we have indications and contraindications again of why you would or would not use heat therapy. All right, looking at slide 12, we're going to look at types of thermotherapy. The whirlpool can be used the same as it was in cryotherapy, but this time it is filled with hot water, and again the hydromassaging effect to increase superficial skin temperature. Something we did not talk about yet is a contrast bath, and this can be used. A contrast bath alternates cold and hot tubs, and this elicits a local vasoconstriction, vasodilation, fluctuation to reduce edema and to restore range of motion in chronic injuries. So you use two different whirlpools, one is hot, one is cold. Typically, if I am prescribing this to an athlete, I will tell them to do a 20-minute treatment, and they will, starting in hot or cold, will depend on when I want them to end. So if they are going to go to practice, I want them to end in hot so that they are ready to go up to practice. If they are finishing the day, excuse me. If they are done with practice and finishing, I want them to end in cold, so then they're cooling all their tissues down and reducing that inflammation. So I'll tell them, go in for 20 minutes. If I have a gymnast who's going to go to practice, all right, I want you to warm up for 20 minutes in a contrast bath. So they will go hot, cold, hot, cold, hot. And they will spend 4 minutes in each tub, alternating. 4 minutes in hot, 4 minutes in cold. 4 minutes in hot, 4 minutes in cold, and then ending with 4 minutes in hot. So the treatment is more often used for hot and ending in hot. It is kind of thought of to reset the tissues, to kind of shock the system almost, to get a person ready to go to practice, kind of reset those muscles. There's not a ton of research on this one. It is used very commonly. We're just not always positive why. Moving on, the most common use of heat is a moist hot pack. So heat packs provide superficial heat, and they transfer energy to the individual's skin using conduction. Each subsequent underlying tissue layer is heated through conduction from the overlying tissue, reaching a slightly deeper tissue level than occurs with a whirlpool. Like other forms of superficial heating, deeper tissues, including the musculature, are not significantly heated. The heat transfer is inhibited by subcutaneous fat, which acts as a thermal insulator, and by the increased blood flow through the area, which carries away externally applied heat. Hot packs most often are used to promote soft tissue healing, to reduce pain and superficial muscle spasm while promoting general relaxation, and it can improve tissue extensibility. These are used really commonly. People just want to come in, hey, I need to warm up my hamstring, it's a little sore today. That can be used. Stretching or something like biking is much more effective in heating the tissues as a whole, but for a quick fix, a hot pack is used quite frequently. Next is a paraffin bath. Oh, I'm sorry. So paraffin baths provide heat to contoured bony areas of the body, so fingers, hands, and wrists. They can be used to treat subacute or chronic rheumatoid arthritis associated with joint stiffness, and it can be used to treat decreased range of motion, as well as other chronic injuries and diseases. Sprained fingers, it's really good for. It is also good for oh my goodness, what is the word I'm looking for? Nerve pain in the hand, it can be used for that as well. You take a little tub about this big, and it is filled with wax, and the wax will melt. And then you can take the hand and you dip it into the wax and you pull it out, let it dry a little bit, and then you do that 4 or 5 more times, building a nice layer of wax over the area that you are trying to provide heat to. Because the wax is melted, it is hot, so when you're dipping your hand in there, it is covering the entire surface area with hot. This is why it's so good for these fingers and your hand, because it will contour into the knuckles. It'll contour into every part of the hand, providing very good heat to the entire thing. So once you have it all dipped and covered, you'll take an empty ice bag, or any type of bag, and you'll pull it over the top and wrap it around. So now you're trapping that heat inside the bag, and it's working to heat the entire extremity. I lost my place, sorry. So then when the treatment is completed for paraffin, the wax should be peeled off and returned to the bath so then it can be reused. It will remelt. The mineral oil in the wax helps to keep it all soft, and as long as the person washes their hands before they put it in, it's not contaminating anything. Paraffin wax is not significantly better at decreasing pain or increasing joint range of motion. It's just better at getting into those contours of the different knuckles or joints of the hand. The last one is fluidotherapy, so a dry thermal modality that transfers heat to soft tissues by forced convection. This is not something that I have used very much. Off the top of my head, I can't think of using it at all. But heat is transferred through the forced movements in the unit chamber of heated air and particles, and then they are circulated around the treated body part, making the fluidized bed behave with properties similar to those of fluid. So I'll try to find a video of this one for you guys, because it's really kind of hard to understand unless you see it. Not one of our super important ones. Again, these are all types of superficial heating for thermotherapy. On slide 13, we're moving on to another form of therapeutic modality. This one is used fairly commonly, and it is therapeutic ultrasound. Much different from diagnostic ultrasound or ultrasounds that you use to look at things. This ultrasound is used to provide heat and to provide therapy to an area. We do not see any images with the ultrasound that we use in the athletic training room. Superficial heating agents, like I said, the last ones that we talked about were superficial. Ultrasound will produce temperature elevations in the skin and underlying tissues, and those are going to get to 3 centimeters or deeper in the skin. The methods that we just talked about will only go to about 1 or 2 centimeters deep in the skin. And so ultrasound uses a high-frequency acoustic or a sound wave rather than an electromagnetic energy to elicit thermal and non-thermal effects in the deep tissue, and that's why it can get a little bit deeper and go 3 centimeters or more. So this transfer of energy takes place in the deep structures without causing excessive heating of the overlying superficial structures. And the actual mechanism of ultrasound is produced via the reverse piezoelectric effect, and it converts electrical current to mechanical energy as it passes through the piezoelectric crystal. So there's a little crystal inside, and you can see it on the picture that I've included. There's a crystal inside the ultrasound head, and that is what converts electrical current to mechanical energy as it passes through the crystal and then through the transducer head. Thermal effects from ultrasound will increase collagen tissue extensibility. It can increase blood flow and sensory and motor neuron velocity. It can also decrease muscle spasm, joint stiffness, inflammation, and pain. You can also turn an ultrasound into a non-thermal modality, and you can increase skin permeability and decrease the inflammatory response, which can also reduce pain and facilitating the soft tissue healing process. So you have pulsed or continuous ultrasound, and both of those will reduce nerve conduction velocity of the pain fibers. So on slide 14, we look at the ultrasound wave. So unlike the electromagnetic energy, sound cannot travel through a vacuum. So sound waves such as these produced by a human voice, those go in all directions, and that principle allows people to hear others talking, even if you're positioned behind them or not looking at them. As the frequency increases, the level of divergence decreases. So like sound waves, the frequencies used in therapeutic ultrasound will produce collimated cylindrical beams similar to a light beam leaving a flashlight that have a width slightly smaller than the diameter of the transducer head. So the effective radiating area is the portion of the transducer's head portion of the transducer's surface that actually produces the ultrasound wave. So here on the slide, there is an equation. So this is how you decide what kind of ultrasound treatment to do for any certain kind of injury. And there is going to be a YouTube video for ultrasound as well, so you can look at that, and it will talk about your duty cycle, your duration of pulse time, and then your pulse period, which is time on and time off if it's not continuous. So watch the YouTube video. I think that'll really help you understand what we're looking at for ultrasound. So we use therapeutic ultrasound, moving to slide 15. In the clinic, we use it to manage soft tissue conditions such as bursitis or tendinitis and muscle spasms. We use it to determine the presence or absence of tendon tears. Sometimes you can tell that. You can use low-intensity pulse ultrasound for wound healing. You can also use it in conjunction with other modalities such as a hot pack. In order to use ultrasound, you need to have a coupling agent, so you have to use a gel in order to perform therapeutic ultrasound. You can use it in water. It's not super common to use in water, but you can use that if your transducer head is too big for the area that you're trying to ultrasound. Then the last part that we can use, it's called phonophoresis. So we can add a medication to the gel that we're using as our coupling agent, and then this technique will use the ultrasound and the sound waves to transport that medicine through the through the skin surfaces, and you can absorb the anti-inflammatory drug through the skin to the underlying tissue. It's probably my favorite way to use ultrasound. On slide 16, we're looking at indications and contraindications of why you would or would not use ultrasound. We can look through those. Over the eyes, definitely don't want to do that. Over stress fractures, if you use ultrasound over a fracture, it will elicit pain. And so sometimes ultrasound can be used to diagnose a fracture or a stress fracture, but it's really not indicated to be used as a therapeutic modality over a fracture. So again, watch the YouTube video. If you have questions about ultrasound, please let me know. It's one that's really hard to conceptualize unless you use it. So watch that, and then please let me know if you have any questions. All right, so then we are moving into electrotherapy on slide 17. Let me see here. All right, so electrotherapy. It's a popular therapeutic modality that can be applied to injured or immobilized muscles during the early stages of a therapeutic exercise program. You can use it when the muscle is at its weakest point. So the various forms of electrotherapy are used to decrease pain, to increase blood flow, to increase range of motion and muscle strength. You can use it to re-educate muscle, to facilitate absorption of anti-inflammatory, analgesic, or other anesthetic drugs to the injured area. And then you can also use it to promote wound healing. So on slide 18, we're talking about the principles of electrotherapy. Electrical energy flows between 2 points. In an atom, protons are positively charged, electrons are negatively charged, and neutrons have no charge. So equal numbers of protons and electrons produced balanced neutrality in the atom. Transfer of energy from one atom to the next involves the movement of electrons only from the nucleus, thereby creating an electrical imbalance. This subtraction and addition of electrons causes atoms to become electrically charged, and such atoms are then called ions. An ion that has more electrons is said to be negatively charged. An ion that has more protons is said to be positively charged. Ions of similar charge repel each other, whereas ions of dissimilar charge attract one another. The strength of the force and the distance between ions determine how quickly the transfer of energy occurs. And so on this slide, I added a YouTube video for you to go in and look at what is happening when we apply electrotherapy. On slide 19, we're talking about the different kinds of electrical stim units. There are many, many different kinds. There's a lot of different ways to set it up. So we're just going to cover some basics. And then on slide 20, I'll go back to slide 19, but on slide 20, I talk about 4 different kinds of neuromuscular electrical stimulation units, and then all of the indications and contraindications for those units. So going back to 19, we're looking at different types of electrical stimulation units. So the first is a transcutaneous electrical nerve stimulation, or a TENS unit. And here we go. A TENS unit are typically portable. They are biphasic generators with parameters that allow pain control through electrical pulses, having short duration, high frequency, and low to comfortable current amplitude. Electrical pulses of long duration, low frequency, and comfortable to tolerable current amplitude. This one is called kind of acupuncture-like because the pulse frequency is low, which resembles that used in acupuncture therapy. So you feel like this little buzzing going through your muscle. Again, this one I wish that you could feel because you cannot explain what it will be like to a patient unless you have done it on yourself. So watch the video, listen to how he is cueing the patient and what he is telling him that he might feel through that. So a TENS unit can produce analgesia and decrease acute and chronic pain, as well as pain associated with delayed onset muscle soreness, although the duration of the analgesia is unpredictable. Often a TENS unit is used continuously after surgery in a 30 to 60 minute session several times a day. It is thought that the TENS can work to override the body's internal signals of pain. So again, we're going back to that gate control theory and how this TENS unit can come in and kind of moderate pain that way. Most of these units are small enough to be worn on a belt, and they're battery powered. The electrodes are taped on the skin. A lot of them are sticky, but sometimes they're taped to the skin to stay in place. For individuals who have allergic reactions to tape or adhesive, electrodes with self-adhering adhesive are also available. Next, we're looking at a high voltage pulsed stimulation. And this is used as a monophasic current, so there's only one phase here with a twin peak waveform, and it's relatively short pulse duration and a long interpulse interval. So this one, high volt is not used super often. You can use it to modulate pain, again with gate control, but it's often used to re-educate muscles. So more often this one is used after surgery. And you use this stim, and then the patient will also work range of motion at the same time. You can use it to increase joint mobility, to promote dermal wound healing, and to decrease pain, edema, muscle spasm, and muscle atrophy. So working to re-educate that muscle so that you don't lose too much muscle mass after surgery. The most common one that athletic trainers will use is this next one, so a neuromuscular electrical stimulation. These units are designed to elicit a muscle contraction of moderately high intensity with relatively little patient discomfort, and they typically involve a biphasic current with a duty cycle. It's used to reduce edema, pain, and muscle spasm during the acute phase. It also is used to exercise the muscle and to delay atrophy. You can maintain muscle size and strength during periods of immobilization. You can re-educate muscles and increase blood flow to the tissues. Low intensity stimulation, galvanic stimulation, Russian current, and Therapeutic current are ones that are not as commonly used. So we're going to go and skip down to iontophoresis. I have used this before. We do not currently use it at SPU. But it uses a monophasic waveform with a peak current amplitude of up to 5. And so this iontophoresis is used to drive medication into the areas of injury. So it's used as a local anesthetic. It can be used to treat inflammatory conditions such as arthritis or myositis ossificans or plantar fasciitis. And so you put medicine into the pads. These are one-time use pads, and stick it on the area of pain, and then the medicine is being driven down through the electrode current. Again, on slide 20, the indications and contraindications are all listed for you. So you can go through those and look at them. I think when we assign the homework, I'm going to use an article for homework this time, and I think those will help you get more of a better idea of what to use and when. Next, we're moving on to massage, and this is a very commonly used modality. Massage involves manipulation of the soft tissue to increase cutaneous circulation, to increase cell metabolism, and to increase venous and lymphatic flow to assist in the removal of edema. As a result, relaxation, pain relief, edema reduction, and increased range of motion can be achieved. So to reduce friction between the patient's skin and your hands, particularly over hairy areas, lubricants such as lotion, coconut oil, or powder are often used. So we have 4 types of massage, and those are listed on slide 22. The first is effleurage. It is a superficial longitudinal stroke to relax the patient, and when applied toward the heart, it reduces swelling and aids in venous return. It is the most commonly used type of massage, and it begins and ends each massage. So effleurage permits the clinician to evaluate the condition, distribute the lubricant, warm up the skin and the superficial tissue, and it helps promote relaxation in the patient so that they are ready for a more in-depth massage. When we're talking about massage for therapeutic modality, we're not typically talking about a massage that you go out and you pay to get. Those are for relaxation. These kinds of massages we're looking to use as a therapeutic modality and to help relieve injury. So a lot of times they don't feel super great because they can be quite uncomfortable. Next, we're moving on to petrissage, and this consists of pressing and rolling the muscles under the fingers and hands. It's more of a milking action over the deep tissues, and the muscle increases venous and lymphatic return, and it removes metabolic waste products from the injured area. It breaks up adhesions within the underlying tissues, it loosens fibrous tissue, and increases elasticity of the skin. So this one, not super comfortable. We're looking to break up tissues. If there's a big knot, if there are adhesions within scar tissue, we're using petrissage as more of a forceful massage to get those things out. The next one is topotement. It uses sharp, alternating, brisk hand movements such as hacking, slapping, beating, cupping, or clapping to increase blood flow, and it stimulates peripheral nerve endings. Because this technique is used for stimulation and not for relaxation, it is not used in most massage treatments. Cupping is probably the most common one now, and we're going to talk about that on the next slide. The next one is vibration. It consists of finite, gentle, and rhythmic movement of the fingers to vibrate the underlying tissues. Also, we have machines now that will do that for us using a DMS, a deep muscle stimulator, or using a hypervolt massage gun. Those are much more common ways of doing vibration massage now. The last one is friction, and this is the deepest form of massage and consists of deep circular motions performed by the thumb, knuckles, or the ends of the fingers at right angles to the involved tissue. These deep circular movements can loosen adherent fibrous tissue or scar tissue. It can aid in the absorption of edemas or working out any buildup that's in that muscle, and then it can reduce localized muscular spasm. Transverse friction massage is a deep friction massage that is performed across the grain of a muscle, a tendon sheath, or a ligament. So if our tendon is up and down this way, we're going to do a cross friction massage going this way to try and break up any adhesions that are happening in that tendon. So a common way to use this is in the patellar tendon after an ACL surgery. A patellar graft is taken, so then there's a scar along the patellar tendon, and then you can build up scar tissue on top of that tendon, so you'll use friction massage or cross-friction massage to break up those adhesions. Cross-friction massage is the most effective technique and is used to break up those adhesions like we just talked about. It promotes healing of muscle and ligament tears. So those are the 5 types of massages. Again, most of the time, you'll use more than one of those in a massage. You're not just using effleurage the whole time. You're actually looking to treat the area, so you will use petrissage and friction sometimes in combination for those treatments. All right, slide 23 is our last slide, and we're just covering a couple other modalities that we use in the training room. The first one is Graston massage. So the Graston technique is a form of manual therapy known as soft tissue instrument-assisted mobilization. It's one of a number of manual therapy approaches that uses instruments with a specialized form of massaging or scraping the skin gently. Again, you have no idea what this feels like until you've had it done on you. It is not comfortable. Using it to break up adhesions or tightness in a muscle, or if you have knots in your muscle, you'll use grass-seed massage to break those up. These tools can be very different depending on what muscle group you're using them on. The one in the picture here is curved like this, and they're using it over the deltoid muscle in the shoulder. Grass-seed massage can be applied to all large muscles, but it can also be used in smaller areas such as around the ankle and the malleolus, and breaking up any adhesions there. The last modality that we're going to look at is cupping therapy. And cupping therapy is a form of alternative medicine in which a local suction is created on the skin with the application of cups. They can be heated, but more than likely now you're using either a silicone cup and using just suction that you create, or you're using a cup that has a gun and it will suck out the air for you. Excuse me. More and more it is common in America. We use it. I use it almost every day now. Again, in combination with some of these other treatments. Once you do a cupping treatment, then you want to do a massage a little bit through the tissue to break up all of the adhesions that you just made. Again, this is a overview of what these modalities can be. I wish we could be in the athletic training room and going more in depth. I wish you could all be feeling what these feel like and practicing them on each other, but right now we just can't do that. Some of you might have had some of these done on you. Some of you might have done them in a clinical setting, and that is great. But if you do go on to a program, a graduate program, you'll use these techniques and you'll have an entire class, hopefully a whole quarter of class, and then clinical settings where you'll get to practice all of these. Again, use the YouTube videos that I'm going to link for you on the slides. They will help you try to get a better understanding of what these modalities look like, what to expect, what to tell a patient, and then I will also email you with your assignment for this week that will be due next Wednesday. I will upload all of this today, and then please email me if you have any questions or anything regarding class, or if you need help in with any services that you might be needing, or if you're having trouble getting these videos to work, or if you're having trouble with Canvas. I know I'm having some problems with Canvas, so please just reach out if you need anything. Just let me know.